So I will be developing a little more discussion around one of the major complications of pregnancy that we've already heard a little bit about, and that is prematurity, or being born too soon. And I'll tell you a little bit about the social, the environmental and the biological factors that have an impact on the timing of birth and whether or not a baby is likely to be born early. And importantly, how we now understand that many of these factors seem to interact. And together they are so important because prematurity is the single greatest cause of death and also lifelong disability in children. And this has now been announced by the WHO with being born too soon overtaking diarrheal diseases as the major worldwide problem affecting our children. And of course, with the enormous number of babies born prematurely, this is a huge factor that affects many families, and the impact can be devastating and the consequences for children can be lifelong. So preterm birth affects, depending on which country you look at, some 5 to 18% of all births. And importantly, in every country in the world, the rates are increasing, and we don't really understand why. And this is a major issue, as you can imagine. And particularly for very preterm and extremely preterm babies that are born less than 28 weeks of pregnancy, there can be major lifelong adverse health consequences, which mean that these children don't reach their full lifetime potential. So, that is really a worry. And the consequences can be neurodevelopmental impairment, cerebral palsy, and learning difficulties, hearing or vision loss, respiratory complications, or problems with the way the gastrointestinal tract works. So these are things that affect children in the weeks and months after birth, but go on to affect the health of those children right through their life. Importantly, even those children who are not born very preterm, so perhaps less than 37 weeks of gestation, are also affected. And we now understand that many of the non-communicable diseases that are affecting our community, with things like neurological and behavioural problems, things like autism, again feeding into learning difficulties, also metabolic disorders affecting later life development of heart disease and diabetes, and additionally immunological disorders, allergy and asthma, are increased in prevalence in children that are born even moderately preterm. So this is a global challenge. As we've heard from Rob, some 15 million babies every year are born too soon. Of those, 1 million will die. There's local relevance. This isn't just in countries like Africa that we've heard about. In every country of the world, the incidence is high, and in Australia it's 8.5%, and it's increasing, up from 7% some 15 years ago. It's especially important because the rate in our Indigenous women is terribly high, at 15%, and we must do something about this. So nearly 24,000 babies are born preterm in Australia every year, and more than 1,500 of those here in South Australia. It doesn't just affect those babies, but importantly, of course, affects their families and society as a whole. The single greatest cause of the cost of running every women's and children's hospital in our country and around the world is prematurity. The cost of neonatal intensive care is more than $3,000 a day, for individual children reaching over $200,000. And of course, the emotional and psychological cost to families and the lost productivity to those families have consequences for us as a society. The topic today is about social inequality and the impact of social disadvantage. So in lower income countries, on average, 12% of babies are born too early, a higher rate than what we see in better off countries like Australia. But surprisingly, some of the countries that we might expect to have low levels, like the United States, have high levels, some more than 12%, with particularly some subsectors of the community, the non-white and the poorer sections of society, almost always more adversely affected. More than 90% of extremely preterm babies in our society will survive due to great hospital care. But in low-income countries, many of these will die within the first days of life, and less than 10% will survive. And within all countries, poorer families are at higher risk. So we are doing fantastic things to improve outcomes for preterm babies, particularly in countries like Australia and other parts of the developing world. And Australia and New Zealand have a very proud record in this, with work by our Montliggans in Auckland, Caroline Crowther here in Adelaide and others, really making profound impact on the health of babies that are born too soon through understanding how we can use steroids to allow the lung to mature and give those babies a better chance at life, and other interventions like magnesium sulfate to reduce the likelihood of cerebral palsy. Now, really importantly, there is fantastic work going on in Australia to come up with new advances to treat these babies better after they're born and to increase the chances of a life where they'll live and where the risk of complications is reduced. So I'm highlighting just a couple of really good, I think, pieces of work going on here at Monash, where very high-tech approaches are now being taken, including using the synchrotron and magnetic resonance, to really understand how the organs of these babies that are born too soon are impaired, and how we might then come up with better ways of allowing those organs or assisting those organs to mature so that we can help those little ones do well. We also have very exciting research in Australia with people from this society, again from Monash, doing fantastic work with stem cells to see how those stem cells can be administered to the fetal lung or in other tissues to improve the maturation and the function of those tissues. And this is great to finally see really high-tech, first-rate, cutting-edge science being applied to the reproductive and pregnancy setting. But the second part of the solution, I think, is not just to improve the prospects for preterm babies, but to try and do something about reducing the incidence. So the first way to reduce incidence is to be able to identify who is at risk. And as we've heard from Claire Roberts, the capacity to develop tools and predictive ways of figuring out who needs extra care is really coming forward, and that's fantastic because it means we can triage those women and make sure they get the care they need. But it's complicated. As we've heard from Claire, there are so many predisposing factors, so many of these that seem to all work to be triggers for preterm birth. Now, how can that be? Things like multiple pregnancy, insufficient suboptimal nutrition, exposure to pollution, infection, genetics that predispose you, asthma, even psychosocial stress. All of these seem to be linked with the likelihood of preterm birth. And this presents us with an incredible scientific conundrum to understand how all these factors are interacting. To make matters worse, there are new triggering factors emerging, and air pollution, particularly exposure to exhaust in very polluted cities, with women who live close to freeways or very busy highways seeming to have more than a substantial increase in the likelihood of preterm birth. And just recently, a very compelling paper published from Harvard on the likelihood that the endocrine disrupting chemicals found in plastics, the phthalates and bisphenol A, also being linked with preterm birth, so that women who have preterm birth have five-fold increase incidence levels of phthalates in their urine. So I think there's really exciting science coming forward now on predicting who is at risk And as we've heard from Claire, finding genes and environmental factors that predispose and understanding the way they interact. And this will help us develop new diagnostic tests and predictive tools. But they require a lot of money and very large international efforts. Surely the ultimate, though, part of the solution is to do what we can to prevent preterm birth. Now, this sounds like an incredible challenge, and I really believe it is, but I think that we are now in a position where it is tractable and we can tackle it. And the scientists here in the room and in Australia are going to make really important contributions to that. But it won't be simple. The solution will reach from cells through to cities and environments and societies as a whole. So I guess we'd all like a simple solution where we develop a drug and take a pill and that will make that preterm birth go away. Well, that's unlikely to happen, or at least in as very simple way as that. Importantly, we also need to understand these causes, develop and adopt effective protective interventions. But all of this rests on understanding the underlying biological pathways and the mechanisms by which all of those different triggers are interacting to impact the timing of birth. So to do that, we have to understand, well, what are the normal pathways to on-time birth? And it always amazes me that we can put men on the moon, but we don't understand what it is that drives the timing of birth fully in women. We're getting much closer through the fabulous work of people like Roger Short and his group in Newcastle, but we have more work to do. So we can learn from that and think about... Did I call you Roger Short? I am so sorry, Roger. I know Roger Short's here and he's done some fantastic things. It's Roger Smith who's done the fantastic work with CRH and the timing of birth. We do, however, need to really do more work to understand how that relates to preterm birth and what are the pathways through which these factors that cause birth too early to come on. So how is it that things like infection activate the inflammatory cascades that we know are always linked with birth, whether or not they're on time or preterm? So to do that, we have to do some really great fundamental discovery science. We have to use animal models, we have to look at genetics, we have to understand cells, and we have to understand whole organisms, and we have to work in animals, and we also have to work in people. And I think that through taking that sort of coordinated cross-disciplinary approach, we can begin to understand how infection and the sterile insults, the things we've heard about, stretch, stress, exposure to illicit drugs, pollutants, all of these can feed into the same pathways. So there is some work published from our laboratory now that shows that the toll-like receptors are at the apex of the inflammatory cascade, and importantly, these toll-like receptors respond not only to infection, but also to these sterile inflammatory stimuli, the particles in air pollution, some of the chemicals that we know trigger preterm birth, the other kinds of ischemic stressors and other insults all feed into, activate inflammation through the toll-like receptors. And this now then gives us an understanding of how we might intervene, not just at the end stage of birth when the uterus is contracting, but a long way further upstream in the weeks and months before when the parturition cascade is first becoming activated. And that's really exciting because it gives us knowledge about some targets at the top of the cascade that if we block, we can perhaps reduce or slow down the progression of all of the steps that result in the contractions and the birth. So there's some fantastic work coming out of Perth that's looking at this, development of new antibiotics that are able to access the deeper tissues of the membranes and even the fetus to reduce the importance of the bacteria, and obviously that's crucial because infection is a key cause in many of the preterm labour incidents. And also in our laboratory, we're working on anti-inflammatory molecules that target the toll-like receptors to allow us to block preterm labour induced by infectious challenges. And here's a fantastic one using a drug that's an isomer of a commonly known drug, naloxone, that binds the toll-like receptor to inhibit E. coli-induced preterm labour. We also are working with fantastic chemists in the US and Canada, and here we have allosteric inhibitors of the interleukin-1 receptor, also showing fantastic, I think, promise in blocking the birth cascade induced by infection. But there may be less high-tech and even interesting nutritional interventions and ways we can improve our diet, with some promise being demonstrated by an interesting observation that administering fish oil in all women extends the length of labour by a couple of days. And if we can learn what that means, we might be able to apply it to women who are at risk of preterm labour. I'm being asked to wrap up. Not without showing that I think that importantly we've got a lot to learn, because the way you are conceived has an impact on your likelihood of preterm labour, suggesting these pathways go right back to conception. So babies who are conceived by IVF having a 2.3-fold likelihood of preterm labour. Much to learn about the biology from that work. And just to wrap up, I think that what this is telling us is that there are common pathways that underlie all of these pathways to preterm birth. The immune system is crucial, and when we understand that, we are in a position to apply new interventions, develop new drugs, and really do something about this. But that will only work if we put the biology and the medicine together with the public health and other strategies. We have to educate women and their families to change behaviour, persuade governments and communities to prioritise infant and child health, and I think provide better access to contraception and preconception care to all women, and empower women not just to know about it, but to access it and use it. And that's it. Thank you.